All right. So I'm gonna get started with just a quick announcement. So this is the last session before our summer break. So we'll be off for a couple months and then back. So just be on the lookout for update messages in your email at the end of the summer. And hope everyone enjoys their time. And then I think we can probably go ahead and get started. So, hi everyone. My name's Ben Solomon. I'm an instructor at Stanford and also a member of the ECI committee. Thanks for being here this evening. I'm going to be starting off with my case for the first half of the hour. And so, for my case, I'll definitely be touching on the important clinical aspects of this particular patient, but I'm also going to be focusing on how we work through the interpretation of an unusual variant and maybe address some pitfalls that could help you all avoid the same things in the future. So hopefully by the end, this title will seem like a good fit. And to get started, I'm going to jump right in with our patient presentation. So this is a 5-month-old girl who presented with neonatal urticaria. And so she presented at birth with a classic blanching maculopapular rash, well demarcated, irregular borders, and was visible even within the first 48 hours of life. She initially had a couple of admissions within her first 3 months of age for febrile URI-like infections, as well as diarrhea and failure to thrive, though her weight did recover spontaneously. During these admissions, allergy and immunology was initially consulted for lymphocytosis and eosinophilia. This was thought to be reactive and did resolve before discharge, and so didn't really become the major part of her story, but did lead to eventual outpatient follow-up, which was first conducted at about 5 months of age. And at that point, her history had demonstrated that this rash that she was initially demonstrating at birth had been constant through this entire 5-month phase. In addition, it was non-pruritic. It would fluctuate over 1 to 2 day periods and would involve her torso, her face, her palms, and her feet. In addition, there was no fever associated with the rash and no arthropathy or ulcers and no other kind of unusual features of the urticaria, such as purpura, bruising, scarring, and there was no associated lymphadenopathy or conjunctivitis. And so next, I'm going to show some pictures of the rash, which is what we have here over a couple different points in time, including the rash at 5 days old, a couple days later, as well as that first outpatient evaluation at 5 months old. And so you can see some of those descriptions of that well demarcated border, particularly at 5 months old. This does kind of look like what you would expect from a typical urticaria, but then also on the bottom demonstrating that there are some more unusual features in terms of the distribution on the palms and the soles. And so then turning towards some of the diagnostic evaluations we did, so starting with infectious disease, during those admissions, she did test positive for a variety of viruses, including rhinoentero, human metapneumovirus, and parainfluenza, but no bacterial or fungal infections. That includes from blood culture. On her immunological evaluation, she had elevated immunoglobulins, as well as elevated relative B cell numbers. Then for some things more related to autoimmunity, we tested for a variety of autoantibodies and complement, and these were all normal. More related to heme, her tumor lysis labs were normal, and looking more at a monoclonal gammopathy, she had normal free kappa and lambda light chains and a normal immunofixation. And then, not surprisingly, during these periods when she was sick, as well as when she had the rash, she did have elevated broad inflammatory markers, including CRP and procalcitonin. And then, due to some of the more unusual aspects of her history, we did opt to do a biopsy of her rash. And this came back notable for this neutrophilic dermatosis with an eccrine gland tropism. And that's demonstrated here on the right, where you can see this kind of neutrophilic infiltration. And it is focusing around these various secretory glands in the dermis. And so at this point, I'll pause just for a few seconds in case people want to enter some thoughts into the chat about a differential that we can start with. And yeah, we see very inflammasomy to start with, which is great. see if anything else pops up, and then we'll kind of just go through some top items. Yeah, we have CAPS, Doc 8, Stat 6. All right. That is pretty good. So I think we'll touch on most of those. And so a lot of information here on the slide, mostly just to kind of look over, and I think will be familiar to most people. But these are sort of the top things we were considering, and broken down here in terms of the more urticarial differential, as well as this neutrophilic dermatosis differential. Highlighting up top, again, some of the unusual features about urticaria in this patient, notably the neonatal onset, the fact that it wasn't itchy, involving the hands, feet, and the face, as well as this neutrophilic dermatosis histology associated with it. And so just to quickly go through each of these, and how it pertains to our patient. So we already noted how the urticaria wasn't quite typical, as we might expect for classic urticaria in terms of its timing, the lack of itching, and its distribution. Moving on to urticarial vasculitis, also seemed unlikely due to the absence of pain, normal complement, and inconsistent histology. Then moving on to plaid, when starting to think of some of the monogenic disorders. So this could be something to think about, but the timing and the histology didn't quite fit, and there was no evidence of an antibody deficiency. And then thinking a little bit more about the neutrophilic dermatoses specifically, one of the most common situations to see that is with Schnitzler syndrome. But here, this is something that tends to affect adults. And as we talked about in the results, she did not have any evidence of a gammopathy. And then skipping over to some of the rheumatological conditions, while these can be associated with the neutrophilic dermatoses, they also didn't quite fit the overall clinical picture, as well as the laboratory testing that we didn't have. So we did indeed start to hone in on the possibility of CAPS, or cryopyrin-associated periodic syndrome. And since this was our leading diagnosis, I wanted to quickly run through some of the features of this condition. So CAPS represents a family of related autoinflammatory conditions, all involving dysregulation of the NLRP3 inflammasome. They broadly fall on a spectrum of severity, starting from FCAS, then going on to Muckle-Wells syndrome, and then on to NOMID. The more mild FCAS presentation involves recurrent cold urticaria with fevers, arthralgia, and various elevated inflammatory markers. And then when you move on to Muckle-Wells, you start to add more CNS-related symptoms with things like hearing loss. And then finally, in the most severe versions that are compatible with NOMID, this can involve things like aseptic meningitis and developmental delay. And as I mentioned, these all involve dysregulation of the NLRP3 inflammasome, which tend to involve gain of function variants leading to unregulated activation of the inflammasome and production of inflammatory markers. So not surprisingly, even before we were really focusing in on CAPS, we were thinking about sequencing due to some of the atypical features of the urticaria. And so when we saw this VUS in NLRP3, we were very interested in thinking a little bit more about it. In the case of CAPS, there are actually proposed diagnostic criteria which take into account the strength of genetic evidence. And most notably, this focuses on the distinction between NLRP3 pathogenic variants and variants of undetermined significance, and how this relates to how many symptoms you also need in order to make that diagnosis. And in our case, our patient only of these symptoms only had urticaria, and so with their VUS wouldn't quite meet these particular criteria. And so we probably wouldn't have had too much trouble to make the case for starting therapy at this point for presumed diagnosis of CAPS. But given these specific criteria and the fact that our patient was very young, we were interested to see if we could find more evidence to more firmly solidify the diagnosis. And so to see if we could squeeze out any pathogenicity out of the variant, we can take a look at the classic ACMG guidelines for variant classification. The main reason for showing this is just as a reminder of the broad categories of evidence. as well as the level of strength that can be associated with each of them, represented here by the rows and the columns, respectively. And then turning to the sequencing report, we can start to fit the different pieces of evidence into these categories. Um, so starting out, looking at population data, we see that this variant is not found in the NOMAD database, and this is compatible with a moderate strength of evidence. There are numerous things that could be counted as predictive data here, but the most important one is that the variant involves a residue that has other known pathogenic variants associated with it, and that's also a moderate piece of evidence. Um, so far, there's no direct functional data that we can pull in, and there wasn't a family history that would serve as a form of segregation data, though we were interested in getting parental sequencing, which was pending at the time where we were considering all of this. Allelic data is a little bit more relevant in this context to autosomal recessive conditions. And we'll come back to the idea of alternative databases and skip over to the other data, which one of the things that's listed under this category in the guidelines is whether the patient's, quote, phenotype is highly specific for the gene, which is a bit subjective, but in this case, maybe we could apply it here. And so then we can go to the various ways you can tally up these pieces of evidence to classify variants. And so currently we have these two pieces of moderate evidence and maybe one supportive, but altogether still not enough for a classification of likely pathogenic. If the parental sequencing comes back positive for a de novo variant, then we can add a strong piece of evidence, which will bump things up to likely pathogenic. And then if we can pull some data that is supportive from some sort of expert level database of information, that can add another supportive piece of evidence, which could be enough to bump it up to pathogenic. And then finally, as a last point, if for some reason one of these expert databases were to reveal that we actually already know about this variant and it has been demonstrated as pathogenic, that plus de novo data would be enough by itself to classify this variant as pathogenic. So, based on this, we were wondering, are there any other unique databases that might help us in thinking about this variant? And as many of you probably are thinking as well, there is one. And in this case, it is the InFevers database, which is a very nice, comprehensive database of variants related to autoinflammatory disorders. So you can go in here and look up NLRP3 and see what the expert community surrounding autoinflammatory disorders has reported for variants in this gene. And so we can go ahead and cross-reference our sequencing results with the variants that have been reported in the same location in InFevers, and this is what we have. So we have our variant up top, as well as the variants reported for the same position 262 at the bottom. And so what you may be noticing is that there is something a little bit unusual here. And so I'll pause for just a couple seconds to give everybody a chance to look at it again real quick and see if it's popping out. And so what everyone's probably noticing is that there's a discrepancy here. So why does our sequencing lab say that the expected residue at 262 is arginine, while InFevers is saying that the expected residue at the same position is valine? And so what you might then go on to ask yourself when thinking about this question is, well, what is the sequence supposed to be? And so how would you go about trying to figure out what is the intended sequence? And so there are lots of bioinformatic resources that might be useful here, but one of the most standard would be the NCBI gene database. And so you can go into this database, look up a gene, and get all sorts of useful information. The one in this particular case would be actually trying to find the sequences. So you'd scroll down to an area where it's talking about different transcripts, and you would see all of these different options. And they're referred to here as these reference sequences. So the question here is, what is a reference sequence and why are there so many? And to answer that question, we got to talk a little bit about the pipeline for identifying genomic variants from that sequencing data, that sequencing sample that you send in. So this is a very, very broad overview of all of the steps that go into taking a sample from submission all the way to that nice report that we get back from clinical labs, including highlighting some of the most important steps, which involve turning that sample into a genetic library, actually sequencing that sample, mapping it to a genomic reference, but then also utilizing a transcript reference for the actual annotation of the variant that gets reported to us. And so we'll talk about some of these steps. So for that first one, the library preparation and the mapping to the genomic reference. So I think everyone's probably pretty familiar with this, but majority of clinical sequencing is so-called short read sequencing, where patient DNA samples are broken up into these 100 base pair or so fragments to be sequenced. And then after that sequencing is done, that data, those 100 base pair data segments, have to then be put back together like a puzzle in order to understand which genes they came from. And this would be very challenging if all you had were the fragments. And so the way we do this more efficiently is by using the human genome sequence, the known human genome sequence, as a scaffold to easily map these fragments into their correct position. And this scaffold is the one that's called the genomic reference. But as I mentioned, there's also this transcript reference. And so why do you need both? And the reason for this is because, as everyone's probably pretty familiar, most genes in the genome don't just produce a single mRNA transcript. They produce multiple isoforms due to things like alternative exon splicing. And so this is a diagram that represents that schematically. Up on the top, we have a hypothetical RNA sequencing or just sequencing data from a brain tissue where the height of the panels just represent the amount of reads mapped to a particular section. The next track down, and I'm going to try to pull out a little highlighter here. The next track down here represents the genomic reference sequence with all of its associated exons. And then below that are some various mRNA reference transcripts, A, B, and C. And so we're going to focus on exon 3, where you can see that the transcripts actually differ. And comparing these sequences to comparing these reference transcripts to the sequence, you can start to see how transcripts A and C are the predominant ones being expressed in this brain tissue. And so it's typically known which isoforms are most predominant in a particular tissue. And so in this example, using only the genetic reference, which does include all of exon 3, would potentially result in erroneous variant classifications if brain tissue is being used because the dominant transcripts there are A and C, and they don't actually use exon 3. So we use reference transcripts to provide context for the types of mRNAs that might be produced in a particular sample. And so now that we know that a reference transcript is needed to contextualize the position of a variant, how do we actually find out which reference transcript was used in our sequencing? And so this is probably a very familiar table that gets attached to the end of all of our sequencing reports that includes all of these genes and these various ID numbers. But this is where you can actually map the specific reference transcript that was used for your gene in your sequencing lab. And so we can go back to our case and look up NLRP3, and we find this reference transcript. And then very conveniently, InFevers also reports their reference transcripts. And in this case, we can see there is a discrepancy here. And so now we can ask, well, does this discrepancy actually explain the difference in the annotation? And to do this, we have to actually find the sequence of the reference transcript itself. And so for this, there's another NCBI database. This one is the nucleotide database, where you can just enter in that reference ID, and then you will be able to pick out the sequence from that page. And we can look at both of these transcripts and see how they compare. And so this is what we see. We have the lab reference transcript on the left and the InFevers reference transcript on the right. And you can see that they are almost identical. But there are 2 additional amino acids at the beginning of the InFevers reference transcript. So effectively, to translate a variant from the lab we used into a variant as annotated by InFevers, you would need to subtract 2. So our arginine 262 proline becomes arginine 260 proline in fevers. And so now we can actually look up this variant in fevers and see what we find. And what we find is that arginine 260 proline has actually already been documented and is classified as pathogenic and validated in fevers, which is great because now we can potentially go back to our sequencing lab and see if we can upgrade this VUS. And just as a quick point, I wanted to highlight this one potential resource called Mutilizer. It makes comparing and translating between reference transcripts much easier than doing what I showed before, which is just placing them side by side. But now to move on to our patient. So what happened next is we presented this information to the sequencing lab, and they did indeed upgrade the classification to pathogenic, though they didn't specifically attribute that to us, as you can see on the right. But after that, we were able to get anakinra approved for the patient. Some additional multi-specialty evaluation did reveal that she had some mild hearing loss, which did improve with time. And then unfortunately, there was a period where she wasn't able to get her anakinra, and this coincided with a flare and possible aseptic meningitis, though she did recover once restarting anakinra. And because anakinra has better CNS penetration, and there's some evidence that it may be better for those with CAPS and neurological manifestations, our current plan is to keep her on anakinra as long as she's tolerating it. But in a lot of other patients, we might have switched to canakinumab once she was big enough because of the more convenient dosing schedule for families. And so with that, I just wanted to touch on this question of, well, how likely is this scenario? Because it does seem pretty unusual. And so just a little bit of data as to, how likely it is that you might encounter this in the future. So something that we did is we reached out to all of these different labs that routinely do immunological targeted sequencing, and we compiled all of their reference transcripts, and then looked at how often these reference transcripts resulted in changes in translational start sites, like what we saw in this case. And so the panel on the left simply looks at the total number of reference transcripts per gene. As you can see, many genes have more than one. And then on the right, we're looking specifically at the number of genes where a change in reference transcript results in a change in translational start site. And so this is showing that, potentially in up to 10% of the genes, the reference transcripts that are being used by these different labs might result in a different translational start site. This isn't to say that 10% of the time, if you go between one lab versus another, it'll change your variant, but it does demonstrate that this is something to be aware of. And one other thing to quickly add about this is that reference transcripts also have versions. So they're periodically updated within their databases. And these versions can also change whether or not the transcriptional start site changes. And on the right, this panel is demonstrating how many versions are associated with genes in these panels. So most of these genes have multiple versions of references. And then the panel on the right is demonstrating how often one of those version changes resulted in a change in transcriptional start site. So still pretty unusual, but it does happen. And this is something to think about as you consider repeat sequencing or reanalyzing previously completed sequencing. And then as a final piece of data from the literature, this is a publication that looked at some other ways that choices within bioinformatic pipelines can potentially impact the specific variants that are coming out of variant reporting. So the top panel is looking at differences in variant classification based on whether the reference transcripts are coming from the NCBI database or the other main database, Ensembl. And the table on the bottom is looking at the difference between variant classification based on the type of software that was used. So this ANOVAR versus BEP. And what you can see is that there is a fair amount of discordance between the results. They tend to agree best when we're talking about things like single nucleotide variants, and worst with larger and more complicated genetic variants like indels. But even with single nucleotide variants, it's still potentially like 10% of the time that you're seeing discordant results. So again, something to think about and realize there are these decisions that are happening behind these reports that can influence the type of interpretations that we're making. So the key takeaway points here, starting with the clinical one, is that urticaria that is neonatal, persistent, non-painful, and involves atypical locations like the hands and feet may suggest things like a cryopyrin-associated periodic syndrome. Like I said, there are many behind the scenes bioinformatic decisions that can influence the final report. And so thinking about, well, how can you avoid this type of pitfall? It's admittedly probably pretty difficult, but one of the things that come to mind is I think what a lot of us heard during our general training when we're thinking about radiology, which is you should trust the report, but always give it your best attempt to read yourself. And I think the same thing goes for genetic testing, where the reports are usually very comprehensive, but it always helps to try to go through it yourself and sometimes cross-reference with these variety of databases that we have access to. And so as my final slide to just talk about those databases. So before a lot of this information is scattered throughout a variety of resources and databases, but there are some good alternatives now that do a great job of compiling them together into one-stop shopping. And one of the ones that I'm using most frequently is this one database called Franklin. And just looking at the way they present the information, which is fairly user-friendly, it would have been fairly straightforward to identify this discrepancy between reference transcripts as opposed to the kind of manual step-by-step approach that we had to do in this case. And so with that, I will stop there. Thank you everyone for your attention tonight. And thank you to those who helped out with the case, some of which I think are on the call today. And I'll stop there for questions. Let's see. So speaking of people that helped out with the case, Dr. Hoffman says, don't forget another option is to contact an expert who is exactly what we did in this case. So Dr. Hoffman, as well as Dr. Broderick, were very, very generous with their time in helping us figure out this case. And as he mentioned in the comments, there is a little bit more history to this particular start site, which we might have to move on to our next case, but definitely reach out to him next time you see him to get a little bit more background info about this. And then let's see, can you talk about the difference between pathogenic and damaging? Does one or both mean the disease causing or high impact on allele expression, i.e. which accounts for mechanism of inheritance? An early frame shift in NLRP3 might be classified as pathogenic because it results in no protein from the allele, but only gain of function NLRP3 variants cause disease. Yeah, I think I understand what you're getting at, in that a lot of these classifications make the distinction between like loss of function variants, which have a much higher degree of pathogenicity associated with them in scoring systems. And usually there are pretty strict criteria for what that means. So for something like a loss of function variant, that tends to involve like large indels, or often splice site variants are considered immediately to be loss of function variants, whereas pathogenic is more of this totaling of various pieces of evidence. And so single nucleotide variants often have to accumulate more evidence to reach pathogenic than something like a loss of function. I'm not 100% sure on the terminology of damaging versus pathogenic though. Okay. And so in the interest of time, I think I will stop there. So again, thank you very much for your attention. We'll now move on to our second case.
Hey there, everyone. Good evening. That was absolutely fantastic. Dr. Solomon, I learned so much. I may reach out to you for your slides a little bit. But what a fantastic talk. So let me uh, share my slides with you all. Okay. Okay. Can you see my screen? Yes. Okay. Perfect. Um, Before I begin, I wanted to take this opportunity to express my gratitude to all of CIS for having an ECI committee and for all the other members on the committee for really being dedicated to lifting up and supporting early career faculty in immunology. And I hope that this trickles down to trainees and other career immunologists because it has so supported me. And it's really a privilege to be here with all of you. Without further ado, I will start my talk. This is an autoinflammatory disease hiding in plain sight. I have no disclosures. So I'd first like to start with acknowledgements. I feel like we wait till the end a lot, but I want to thank Dr. Daniela Schwartz for being my expert supervisor on this case today. It was a chance encounter at CIS that was just sort of fate in that I was thinking about doing this case, and then I meet an expert in this syndrome, and I feel very grateful for her comments and attention, and I'm really thrilled that she was able to join us. Thank you to Sawyer for his organizational skills and for planning this for all of us. I thank the ECI committee and CIS and my own division, and also my family. So the chief complaint, this is a 50-year-old woman who presents with a chief complaint of low IgA and recurrent infections. I see primarily adults, so it is complex to think about all the potential causes of this chief complaint, but also means that we dive in deep into the history. So this is where I am, a National Jewish in Denver, and it's a beautiful place. I hope you come sometime or consider it as well. And I just wanted to point out that we do specialize in complex lung disease, and so in my practice as a clinical immunologist, I tend to be enriched in people with bronchiectasis and ILD. Also on the other side of my clinical coin, severe asthma, eosinophilic lung diseases, et cetera. And National Jewish was one of the sites in the early 1900s for where tuberculosis patients could come and before we knew about germ theory, they could come and get fresh air. And you can see that they're out on the balcony getting their fresh air, which was thought to be good for TB patients. So back to the case. So history revealed recurrent otitis media starting in childhood, which we've heard before, but in this case, it was complicated by mastoiditis requiring a cochlear implant. A little much already right off the bat. And then recurrent sinusitis, status post 3 sinus surgeries. She has required IV antibiotics for sinusitis before and has grown MRSA in her sinuses. She has a history of recurrent pneumonias, and I'll get into the organisms that she's grown in a little bit. At age 48, she was hospitalized with sepsis, so she sort of was mostly in the outpatient setting, even for the IV antibiotics for the sinusitis. But right before I saw her, she was hospitalized with sepsis and found to have multifocal pneumonia. And a bronchoscopy grew MSSA, and the BAL had a neutrophilic infiltrate. She was known to have splenomegaly based on CAT scan, like incidental findings on a CT scan. She had a history of lymphadenopathy, status post excisional inguinal lymph node biopsy with follicular hyperplasia without malignancy. She has a history of iron deficiency anemia as well. And then she has a history of environmental allergies on allergen immunotherapy. So importantly, no history of bacteremia, abscess, meningitis, or encephalitis, no diagnosed autoimmune syndromes. And what I will reveal to you is that she's never seen a rheumatologist. No history of DVT, PE, no history of miscarriages, no history of cytopenias, no endocrine disorders, no known heart disease. And for review of systems, she reports a chronic productive cough, shortness of breath on exertion, nasal drainage, difficulty keeping weight on, and myalgias. And then notable negatives include the GI tract, Her GI tract has sort of always been steady, which is reassuring. No fevers, rashes, oral ulcers, ocular symptoms, or palpitations. And so to continue the case, surgical history was, as I mentioned, importantly, family history, relatively unremarkable, but she has two children with celiac disease. But nobody in the family with recurrent pneumonias, sinusitis, need for cochlear implants, hospitalizations, IV antibiotics, and there's no known consanguinity that she reported. She's a retired chemist. She lives in a house where there is no concern about, uh, you know, um, coal burning stoves or fireplaces or chemical exposures, irritants, mold, infestation, etc. She has two cats and two dogs. She is a high endurance athlete. She's a marathon runner. So the chronic productive cough and shortness of breath have significantly affected her quality of life. I will say, in terms of exposures, she's a retired chemist, but she reported that she had no significant aerosolized exposure to chemicals in her life, but it's something to keep in mind. Never tobacco, no vaping or marijuana, and we always have to ask about cannabis here in Colorado, and 2 to 3 drinks of alcohol per week that do not exacerbate her symptoms. And then up to date on all childhood and age appropriate vaccinations, including influenza, COVID, and received a Pneumovax vaccine 5 years prior. Okay, before we get into the data, are there any questions so far? To do this, I probably need to see the chat. Um, Sorry, I can't see the chat. Get bigger. Oh, oh, no questions. Okay, very well. That's great. Okay, here we go. Right. All right, here we go. So on examination, she had a low grade temp of 99.2, notably her BMI of 19.7. She's fairly thin. And overall, the important things on examination are that she's quite thin. She has a cochlear implant in place, and both the TMs were just white, totally scarred, no landmarks visible, kind of flat, and just seemingly non-effective. I didn't palpate any lymphadenopathy on my examination. Her heart and lungs sounded clear despite her report of productive cough and faint splenomegaly on my examination. But overall, I didn't see rashes, clubbing. I didn't see any nasal polyps. It was overall a kind of like the examination didn't lead me in any particular direction, but I was struck by the ear exam. Okay, so getting into the data, it's so important to start with a CBC and a chemistry because this is, uh, for us in academic centers, we often send all the labs that we can. And in a community setting, this may be what you have, and you be really clever and smart to make inferences and with just routine labs. So importantly, I was reassured by her CBC, to be honest. Um, and um, and then her chemistry, some notable things include a low serum albumin and also a high globulin, but a normal total protein. I was also interested in the LFTs, which were within normal range, and also the creatinine as well. So far, the labs that I ordered for her was my sort of standard immunologic workup. And the outside of the IgG subclasses, which at National Jewish are ordered routinely by pulmonary. And I don't routinely order them, but it was nice to have in this case. So importantly, we do have a mildly low IgA, and this should be bolded, but notably an elevated IgG of 2536. The IgM was normal and IgE was normal, which is important. For the DHR was normal. Her SED rate trend is as follows. You can see here that it was overall in the normal range. And then her C-reactive protein really tracks when she's sick. She is when she has an episode of sinusitis, her CRP is elevated. And when she's had exacerbations, I'll show you her lung CT, her CRP is usually elevated as well. But importantly, we made some intervention here that did drop her CRP, and I'll explain what we did in a minute. So, what I wanted to draw your attention to in terms of the subsets for the T and B cells, we do have a mildly low absolute CD19 B cell count, but importantly, normal T cell counts, CD8 and CD4. We have normal memory B cell populations, and then we do have an increased transitional B cell segment, but I am interested in this immature B cell population that was normal, and her NK cell quantification was mildly low. Okay, now for the autoimmune studies. So her rheumatoid factor was elevated, her ANA was abnormal, and her complements were normal. SSA, SSB were normal. Her cytokines are listed here. IL-10, IL-12, and IL-2 are elevated. TNF alpha is as well, and interferon gamma 2. Her sweat chloride is negative. Anyone with bronchiectasis, oh dear, I've ruined it. Anyway, at National Jewish and in general, she get a sweat chloride, and some of the other rheumatologic labs are here and normal. She has an abnormal thyroid peroxidase antibody, and in terms of titers, she has protective diphtheria and tetanus titers, and borderline, but also fairly impressive. I don't know. It's a borderline response to Pneumovax, truly, but it was more than I was expecting. Okay, so this is her CT scan. So as you can see, so the read was basically ground glass and consolidative opacities bilaterally, including consolidation throughout much of the right middle lobe and part of the lingula with associated bronchiectasis. You can see a little bit of, it almost looks like honeycombing here. But the final read was no definite honeycombing. You really need to see a lot of traction for that. And then there's a couple of nodules as well, adenopathy that includes subcarinal lymph nodes and paratracheal lymph nodes. Ultimately, the final read was multifocal chronic infectious/inflammatory airways disease compatible with chronic infection. And importantly, the degree of underlying bronchiectasis couldn't be well characterized by our radiologists because of the extensive mucoid impaction. And again, a prominent spleen was identified but not measured. So other studies include negative respiratory viral panels. Many times when she's sick, the clinical syndrome was very characteristic of viral syndromes before she went into bronchiectasis exacerbations because she has college-aged kids that would come home sick and she would get sick. But I was worried about an immune defect because so often we have seen that the virus might not be identified actually only on bronchoscopy sometimes is a respiratory virus identified in a patient with immune deficiency, not on a nasopharyngeal swab. And then her sputum cultures, the primary organism that was plaguing her with her bronchiectasis exacerbations was Pseudomonas. When Pseudomonas targeted therapy was used, she felt much better, but then it would come back, and then she did have MRSA in her sputum. She did demonstrate mild oropharyngeal dysphagia on her swallow study, and an esophagram demonstrated mild gastroesophageal or gastrointestinal reflux. And then she did have an endobronchial biopsy, so this is not a wedge, that basically showed basically chronic bronchiolitis. And so if we look at this, like what cells are involved here, basically it says small mature lymphocytes, variable number of plasma cells, and rare eosinophils. So really a mixed infiltrate, but compatible with chronic bronchiolitis. And then importantly, like the pathologist notes all of the various conditions that could be possibly associated with this, as it's relatively non-specific, but it's broad and includes, so like, what do you do with this pathology report? It's so interesting. Systemic autoimmune connective tissue diseases, extraintestinal manifestation of IBD, inherited or acquired immune deficiency syndromes, or possibly lymphoproliferative disorder. And then importantly, features suggestive of asthma, such as eosinophilic bronchiolitis, expansion of the subbasal lamina, goblet cell hyperplasia, or smooth muscle prominence are not present. And then features suggestive of aspiration were also not present, and no evidence of malignancy, which is very important. Okay, so you have this patient who you're sort of thinking, okay, well, maybe this is just bad bronchiectasis, and in the setting of probably aspiration, even though the biopsy didn't suggest that. But there's other parts of her history that give us pause. And so, when do you send genetic testing in adults? So, this is something that I think about every single one of my clinics. And so, I like Dr. Troy Torgerson has given this talk a number of times where he talks about like when do you send genetic testing in general? And I really have used it as a mantra. So if some presentation in the history is too severe, like if they've had, you know, life-threatening influenza, for example, or a single episode of meningitis that, required, craniotomy and drainage of the abscess, like even one episode of something too severe can lead us to do this. Too many, right? We know too many pneumonias, too many ear infections, too many sinus infections, too weird. So that's like multiple things together at the same time. So if you have recurrent pneumonias, but you also have uh, you also have recurrent fevers and hives. These are things that are different. Could they be related together and they're too strange? And then a family history. So in adults, we aren't as pontificating about whether or not an adult is going to transplant or not, as we would do in a child, though we need to consider it in severe presentations. But we're thinking about its implications both for treatment and for family history. So, would the genetic testing affect the management of this patient or family members in future generations? And I thought it was warranted in this case. So, I meant to hide the company here, but in any case, it's obvious. So, panel testing revealed three variants that were reported. The first was a pathogenic heterozygous variant in TNF-AIP3, also known as A20, which is associated with autosomal dominant familial Behçet-like autoinflammatory syndrome. And if you look, I'm still sort of like getting, even 5 years in, I feel like genetics for inborn errors of immunity is something that I'm constantly trying to be better at. So don't worry if you struggle with this, because a lot of us do, particularly in the adult world where we might not have genetic counselors at our fingertips or medical geneticists. But I always phone friends if I have trouble, and that's the beautiful nature of our community. So essentially, in this autosomal dominantly inherited syndrome, this variant created a premature translational stop signal in this gene that is likely related to at least some aspect of her phenotype, but it wasn't perfect based on what I'd read. So let's continue. So what is TNF alpha induced protein 3, aka 20? So it's located on chromosome 6 and it encodes a ubiquitin editing enzyme. And this enzyme plays an important role in many immunologic processes, including the negative regulation of NF-kappa B, ubiquitin editing. It controls cell differentiation of different immune cells and primarily regulates inflammatory cytokines. And it also regulates the NLRP3 inflammasome. I love how this session today became about the NLRP3 inflammasome. I kind of love that I did not see Dr. Solomon's slides ahead of time, and I'm sort of like really happy that we have Dr. Schwartz here who can comment on the whole spectrum of autoinflammatory diseases. So A20 is also importantly involved in regulating cell death, and it also acts as a tumor suppressor, so it has many different functions. And so variants in A20 are known to be implicated in a number of immune-related diseases, including Behçet's disease, polyarticular juvenile idiopathic arthritis, autoimmune thyroiditis, autoimmune hepatitis, and rheumatoid arthritis. And as a primary syndrome, it's been well defined now in basically TNF-AIP3 haploinsufficiency, which is its own monogenic autoinflammatory syndrome. And the A20 protein is highly conserved. It has two main domains, the N-terminal ovarian tumor domain, OTU, and then a 7 zinc finger domain in the C-terminal area. And the majority of variants causing disease are frame shift and stop codon variants that you can see here. Our patient's deletion hadn't been well described, but because it was basically it created a stop codon, the assumption is that it's pathogenic as loss of function in this gene creates a deleterious protein. But you can see that there are a lot of variants that have been identified. And this is just the frame shift and stop codon variants. There are other missense variants as well, but these are the most damaging. So this was one of the earliest reports of this cohort, and you can see our expert, Dr. Schwartz, is on this paper here. And so they reported a number of kindreds with autosomal dominant inheritance, and you could see the various autoinflammatory the autoinflammatory presentations here. And so importantly, I wanted to sort of summarize what's known about the clinical phenotype, but it is a very heterogeneous disease. And so mostly the age of onset in these kindreds is below the age of 18. All of them have oral ulcers. So I'm like, is this really fitting with my patient here? Skin rash appeared in some of patients. And then GI disease appears in a number of patients, which did not really appear in my patient, or did it? Workup is ongoing. So importantly, some patients have multiple autoantibodies and some have none. So really is a heterogeneous phenotype. And notably, about half of patients have some degree of polyarthritis. And then in terms of treatments for this syndrome, we have patients responding to anti-TNF therapy, patients responding to IL-1 inhibition, colchicine as well. And so those are like the more common agents used in this syndrome, anti-TNF, anti-IL-1, and colchicine. And so from the original report, what do we know about these patients? So importantly, what this is showing is that stimulated cells, what it's showing in this first slide on the upper left is that stimulated cells from A20 deficient patients show an increase in ICABB alpha degradation and an increase in MAP kinase activity. And also fibroblasts derived from these A20 deficient patients, so show increased levels of this of ICABB alpha as well. And then if you look at the nuclear NF-kappa B as well in these patients, it's significantly more activated than controls. And then basically in these patients, there's impaired TNF receptor signaling and the deubiquitase function is affected. And I wanted to show this segment here where basically there's reduced recruitment of the mutant A20 to the TNF receptor signaling complex. And then the A20 mutants, it's over here. Yeah. So the A20 mutants lose their ability to deubiquitinate K63 ubiquitin chains. And this is directly related to this essentially proves the haploinsufficiency because there were single variants. So this was the proof that the variants in this gene cause impaired protein function. Okay, and then importantly, sort of to tie us back to the first case, there's spontaneous NLRP3 inflammasome activity in patients with CNFAIP3 mutations in an abnormal way, in a way that's sort of overactive, mimicking our first case. So does this really fit with our patient? So phenotypically, we're thinking about oral ulcers, polyarthritis, GI disease, rashes, and does it really fit? No, it doesn't, right? So I was able to find this case report of haploinsufficiency of A20 being involved in a different kind of phenotype, an ALPS-like phenotype, which did fit with our patient, my patient with recurrent pulmonary infections, splenomegaly, lymphadenopathy, didn't really have the cytopenias, but still. So this case was a 5-year-old Japanese boy with fever, increased CRP, and liver dysfunction who presented acutely with fever and lymph node swelling, noted to have hepatosplenomegaly and bilateral cervical lymphadenopathy, was diagnosed with Kawasaki. However, IVIG was not effective. And then you could see in the labs here, the cytokines associated with ALPS were elevated. So IL-10, soluble, fast ligand, IL-18, and then BAV was normal. And then in the interest of time, I'll keep going, but you can see the increase in the double negative T cell compartment. And treatment with prednisolone, cyclosporin, and mycophenolate resolved symptoms. And so I'm gonna, in the interest of time, continue, but essentially, this the TNFIP3 variant was found to basically cause the phenotype in this particular patient. And so we're thinking about this concept, we think about a lot in our field about different variants. Now, see where this variant was not in the OTU domain. It was a frame shift variant, but it was in the zinc finger domain. And so we think a lot about genotype, phenotype correlations, and whether or not we actually may, patients with ALPS, we may be missing variants in this gene that may be relevant here. And so importantly, there was basically an impairment in cell death that was identified in this kid. Oh, sorry, I wanted to point out that his like platelet count was 6, and that was a significant issue that didn't resolve until the autoinflammation was corrected. It didn't reverse with the IVIG. Okay, so does this still fit with our patient? What about the lung disease? Is this related? Is this a case of a misdiagnosis in the youth of this woman that basically, if this was caught earlier and treated, would the lung disease not have developed? Is the lung disease just related to, maybe she is having some undiagnosed GI disease and she's aspirating, and that's what led to the bronchiectasis. So if we look at the lung biopsy again, it doesn't give us too much of a clue. But I wanted to now, I know we're running short on time here, but I wanted to turn to Dr. Schwartz for her thoughts on this case and particularly commenting on the findings of the lung.
Yeah, so I think one of the things that I would sort of try to hammer home about HA20 is that it's not auto-inflammatory so much as auto-inflammatory-ish. A20 does a lot of stuff. It regulates the NLRP3 inflammasome, TNF signaling, but also type 1 interferon signaling. It's every patient is their own special snowflake of difficult management. I do see IgA deficiency or sometimes hypogam in a chunk of the patients, some before they undergo immunosuppression. So I always get asked, is it because they've been immunosuppressed for a diagnosis of lupus or Behçet's or what have you? And no, it isn't always. There are a few who actually their presenting symptom is CVID, and some of them come into me on replacement IGRT. Actually, I think Dr. Rosenberg may be on this chat and might have referred me one of those patients as well. So it's a very heterogeneous disease, and I haven't seen a ton of bronchiectasis. We have seen recurrent respiratory infections, but it does have about 8 to 10% of the patients have pulmonary manifestations. It's usually pulmonary nodules, very rarely pulmonary fibrosis. I had one unfortunate little boy in New Zealand who had very severe pulmonary hypertension. Unfortunately, he died, which was really tough. So it's a very heterogeneous disease, and I think that until we have better natural history studies, which is a shameless plug for my natural history study and registry that will be opening in fall of 2025, if you have any patients, it will be impossible to say exactly what is directly related to HA20, but I tend to cast a broad net.
Thank you so much, Dr. Schwartz. I think that's a plug for us for those of us who see adults to not shy away from genetic testing. And this, we may have a lot to offer in terms of natural history because we're going to pick up the individuals who have had a delay in diagnosis. So thank you so much for that comment. So about 8 to 10% with lung disease. Very, very interesting. I may have more appear in my clinic then in the next few years. So back to the patient. So I did refer her to rheumatology, and she was started on colchicine, which she has called her wonder drug because it has improved her many of her symptoms. And as you can see, it also improved at least one of her inflammatory biomarkers. Objectively, the objective signs that we have are her, because she doesn't have oral ulcers or synovitis or rashes. We are looking at her chest to see if there's improvement in the lung findings on colchicine, but she hasn't been on it long enough to get to there. But she feels like it's helped her with her breathing. I wonder if that is related to, it could be related directly to the lung, but I wonder if it's more related to musculoskeletal improvements. And so she told me, I didn't realize how stiff I was. She is like this woman who just powers through things and she just runs, and she goes, I didn't realize how much pain I was in. And so she loves her colchicine. I did ultimately start her on sub-QIG for mild specific antibody deficiency in the clinical sense of she did grow strep pneumonia at one time in the last 6 months, and the viral syndromes were getting too much. She still has periodic bronchiectasis exacerbations, but significantly less. And then aggressive airway clearance for her bronchiectasis. So this involves hypertonic saline and aerobica. She's not on inhaled antimicrobials, but sort of sputum cultures for monitoring, especially for like non-tuberculous mycobacteria. We do that a lot with at least sputums quarterly, and I co-manage her with an excellent pulmonologist. So we are considering brensocatib, which is a DPP-1 inhibitor that is likely to be FDA approved for non-CF bronchiectasis this year. And even though the patients with primary immune deficiency and dysregulatory diseases are intentionally not included in the clinical trials for these things, it's possible that they are missed because there are many patients with bronchiectasis who don't get to us. So I think this would also be potentially a good option for her if she continues to exacerbate. We did proceed with genetic testing of her 2 children, which were negative for this variant, and her parents are deceased, so we don't know the inheritance of where she may have gotten this variant from, or if it was de novo. And next steps for her. So we could consider additional ALPS eval for her that was not done. And I think I might pursue that, but she's doing really well at this time. So right now she is in process of being scheduled for endoscopy. And I'm particularly interested in endoscopy and colonoscopy. I'm particularly interested in evidence of inflammation and lymphoproliferation. So could her bronchiectasis be directly caused by this? It's possible. And then we consider escalating to IL-1 inhibition. She's doing very well at this time, and the rheumatologist is very weary, for good reason, with her history of infections, about adding on IL-1 or TNF alpha blockade, but I have to reinforce the concept that uncontrolled inflammation actually increases the risk of infection. And now that she's on gamma globulin, this might we could maybe push a little bit further with those other strategies if she has other manifestations or starts to decline. So the big takeaways, see my cartoon, oh, I get it, I'm IL-1 and suddenly it's all my fault. So don't shy away from genetic testing in adults, but counseling about expectations is important. I say we might not find something that changes my management And we might find something that we need a little bit more investigation to interpret, but it can help us understand you and potentially your family. And then we do need to publish more on atypical presentations of known autoinflammatory diseases or autoinflammatory-ish diseases. And then consider this ALPS-like phenotype in individuals with A20. And then now that we know that some 8 to 10% of patients with A20 haploinsufficiency can present with lung disease, consider that. And then consider early screening for lung disease in patients with this disorder. Perhaps earlier identification could have modified the outcome. So I'd like to once again thank, oh, I'm sorry for, it looks like I misspelled your name. Sorry, I'd like to thank again Dr. Schwartz for being here and for helping with this case and for being a supportive mentor and generally. And I'd like to thank you all for your attention. And I know we are out of time and I want to respect your evenings. Oh, there's so much chatter in the chat. I love it. Great. So okay, let me go back to the top. Okay, other questions. Low MPV, a sign of chronic inflammation. Thank you to Terry for that that comment. I hadn't realized that, but something else to consider in the CBC. Vaccine responses theme. Okay, so type 1 interferon signature. I haven't, this patient is relatively new to me-ish, and so I can certainly pursue that. Would we think about doing that to clarify like whether she would benefit from a JAK inhibitor or would it, yeah. So we could certainly pursue that. And I think that's an excellent idea.
Anecdotally, like 80% of patients with frameshift or truncating mutations have an elevated type 1 interferon signature at some point in their disease. That is not published yet, but just in my cohort, we've now been collecting. And something like we've now started checking the S100 proteins just to see just myeloid activation. And at least again in my cohort, and I'm a rheumatologist, so maybe I'm seeing the more autoinflammatory of the autoinflammatory spectrum. It's more like 85 to 90%.
Interesting. And how did they do on JAK inhibitors? I assume great.
So I generally use JAK inhibitors. So even the ones who go on IL-1 blockers who have really periodic fevers tend to reduce their interferon signatures if they're not super active. If they have massively high type 1 interferon signatures, definitely if they have liver disease, they do quite well on JAK inhibitors. I've only had one patient who couldn't get a JAK inhibitor because he came to me as an adult and it had 4 or 5 MIs by that time because he had lupus and he had he had a very high interferon signature. I mean, something like 1050 on the nanostring, which is like 50 is the upper limit of normal. And he was having periodic fevers with S100 proteins in like the 20,000s. And so he ended up going on anakinra and anifrolumab and is doing really, really well. But in general, either IL-1 or JAK inhibitors tend to work pretty well. TNF in some. For whatever reason, I haven't had as much luck with TNF inhibitors as some of the other people who use it in the literature, but that's probably also because of who gets sent to me and how many of them have had years of uncontrolled disease, because I see adults as well.
I wonder if that's because of the sort of inflammasome activation.
Yeah,
Right.
it could be. I have a feeling that the ones who do well on TNF inhibitors just never make it to Pittsburgh.
Understood. Understood. So I did not send a chromosomal microarray. Should I do that? Okay. Someone messaged me afterwards because I often don't send microarrays in adults, but if I need to be doing that, please tell me. Okay. I'm just looking at the comments. Do HA20 patients have impaired TLR responses? I'm going to defer to Dr. Schwartz.
They would be enhanced because you remember that A20's canonical function is to suppress activation of NF-kappa B and suppress activation of the inflammasomes. So generally, in a patient with HA20, if you stimulate their cells with LPS, they're going to hyper respond.
Thank you. And then, oh, you sort of answered everyone's questions. I see quite a bit of folks with GLILD, and I sequence all of them, and I haven't come up with this before, but and it seems like Dr. Schwartz, you haven't seen anyone in particular, but
Seen anyone with GLILD. I've seen a lot of pulmonary nodules. I've seen a lot of like asthma, asthma, whatever that is. Asthmish, I don't know.
Asmish, yeah.
Asthmish. But a lot of nodules and then the one pulmonary hypertension and a few with, NSIP is the more common thing. But I am a rheumatologist, so maybe I'm not getting those patients who have GLD.
Okay, excellent. Well, thank you so much for helping me with this case, Dr. Schwartz, and for all of your attention. I think if you have further comments, questions, advice for me, feel free to email me. And it was a pleasure to speak to you all this evening as we sort of navigate these tough cases together. But thank you so much for your attention, and I think we can part. We'll see you next month.
End of the summer.
Oh, sorry.
Yeah, we're on
See
break.
you see you next time. How about that?
Yeah. Yes. Enjoy your summer, everyone.
Yeah.
Jessica, great job. Very, very
Thanks.
interesting.
Thanks, Ben. Yours too. All right. Thank you so much, everybody. I might just